Good day, everybody. I'm Professor Lang, and I'm a cardiologist based in Dundee, in Scotland. And I have a specific interest in the complications of cardiometabolic diseases, including obesity and diabetes. Um, I'm an editor of an upcoming special focus issue in European Cardiology Reviews. And today's roundtable discussion is underpinned by this special focus issue. Now, this special focus issue has contributions from across the world, exploring the burden of obesity, together with heart failure and kidney disease, but also importantly, impact of obesity on drug prescribing. So I think this is a very interesting special focus on European Cardiology Reviews. Now, today, in this roundtable discussion, I'm joined by two contributors, and I'll let them introduce themselves. Firstly, Professor Bianca Rocca.
Good day. I am Professor Bianca Rocca. I'm working at the LUM University in Bari. I've been trained as an hematologist in cardiovascular diseases, and I've been working as a clinical cardiovascular pharmacologist for many decades now. Thank you.
Thank you, Bianca. So over to Samira Bell.
Hi, I am Samira Bell. I am a clinical reader at the University of Dundee and a nephrologist. I'm interested in cardiovascular disease and kidney disease, and I'm delighted to be participating in this today.
Thanks to both of you for joining us in this roundtable discussion. So it is a discussion, and today's discussion is focusing on obesity. And I'd like to begin with Bianca because I'm acutely aware that when we prescribe drugs to patients of different physical makeups, and I'm always thinking, well, does obesity impact on the handling of drugs? And should we be concerned about it?
Actually, when we talk of obesity affecting pharmacokinetics of drug, we should really focus on the highest degrees of obesity. So the real challenge is class 2 and 3 or more obesity according to the WHO classification. So what is called moderate to severe obesity. And under these circumstances, actually, all the different steps of pharmacokinetics can be affected, starting from absorption, gastric emptying time is different, gastric motility is changed, and therefore for some drugs, oral bioavailability can be increased. Also for drugs that are given subcutaneously, of course, the thickness of the subcutaneous fat is different, so many antithrombotic drugs are given subcutaneously. For the distribution, there is a major balance between lean and fat body mass, and therefore the volume of distribution of some drugs, the one that are less hydrophilic or more lipophilic, they can actually accumulate and in the fat, so their half-life can be longer, and their area under the curve over 24 hours can be broader. And also, there is usually an increase in acute phase protein in these patients. So this means that free drug may often be less available in obese patients because there is an increase in the acute phase proteins. And last but not least, liver and kidney function are different according to different phases of obesity. At the very beginning, the blood flow to liver and kidney is higher, so there is a higher first pass effect as well as a higher kidney clearance. But as long as obesity becomes a chronic situation, then liver becomes fat and CKD slowly decreases over time. So the pharmacokinetic steps are all affected and might be differently affected according to the length of the, let's say, disease, if we can call it as a disease.
Thank you, Bianca. I mean, thanks for reminding us about drug handling that actually includes absorption, distribution, and excretion and metabolism. And yet, in your opinion, in terms of clinical trials of pivotal clinical trials of drugs that are effective and translated to clinical use, have obese patients, the ones that you talked about in extreme obesity, have they been included in our trials or have they been excluded?
Actually, if we talk about class 2 and 3 obesity, the evidence is very low. If we think that antiplatelet drugs were developed in phase 3 trials when obesity was at maximum class 1, and also for other trials on anticoagulants, class 2 and 3 obesity are often less than 10% of trial population. So they are largely underrepresented. So the evidence is very narrow. On the other hand, we are giving drugs that often are fixed dose, so they might be underdose when obesity is severe, but on the other hand, the lean mass is reduced, and we are also giving drug based on kilos of body weight. And of course, under those circumstances, obese patient can be overdose. So for obese patients, often therapeutic drug monitoring becomes relevant. And also in the future, in silico simulations, taking from real world data may be very important because it won't be really feasible to have obesity targeted, let's say, clinical trials on many drugs that are very much used, for instance, in atrial fibrillation or post-MI or in ACS or in stroke.
Well, thank you so much for clearly giving us a brief insight to what are the potential factors that we should be looking out for, and you will be covering this in this special focus issue of the European Cardiology Reviews. Is that right?
Sure, absolutely.
So therefore, may I welcome the listeners to this roundtable discussion. Do look out for Professor Rocca's exciting issue that talks about drug handling in obesity, and I'm sure there'll be some important educational points from it. Thank you, Bianca. I want to move on now
Thank you
to
very much.
Dr. That was really fantastic. I want to move on now, changing tack completely, to ask Dr. Samira Bell, who's a nephrologist. And I think we all know that there's intense interest around obesity and patients with renal disease, both in terms of impact obesity on renal disease, but also some exciting data to show that some of the drugs targeting obesity may have renal benefits. Samira, do you want to help give us an update on the evidence regarding this?
Sure, thank you. Yes, us nephrologists are very excited about the impact of these drugs on renal outcomes. So over the last few years, there's been several studies. The Leader and Sustain 6 study really focusing on type 2 diabetics at high cardiovascular risk, but showing renal benefit in these patients. But more recently, the FLOW study, which looked at type 2 diabetics with established CKD, again showing renal benefits. And then finally, the SELECT, which was not type 2 diabetics. It was people who had obesity and cardiovascular disease, but no diabetes. And once again, it showed cardiovascular benefits. So again, this is extremely exciting from our perspective. And this opens up a huge new avenue of medications for us.
Yes, I mean, that is reports of studies, almost a very consistent finding that this class of drugs have renal benefits. Those are the clinical trial data. What are the potential mechanisms for this, these renal benefits of this class of drugs?
So apart from the glycemic and weight effects on kidneys, I think there are a number of other mechanisms that are suggested, although it's not completely clear what the renal mechanisms are. But I think it affects the natriuresis, which then reduce intraglomerular pressure, but also lowering glomerular hypertension, which as a result of blood pressure reduction. But also these drugs are thought to have anti-inflammatory and anti-fibrotic properties. And so from a kidney point of view, this is beneficial, as well as reducing lipid accumulation within the kidneys. So I think there's a wide number of potential mechanisms, but I think there's still many that are probably still not really completely understood.
So to summarize that, so there are benefits related to the weight reduction, but there may be renal benefits beyond the weight reduction.
Yes.
Yes.
Yes, absolutely.
And clearly,
Anti-inflammatory, anti-fibrotic.
clearly a very exciting space, and the other class of drugs that is gathering momentum that also has application in diabetes and in obesity a little bit are SGLT2 inhibitors. Do you think there is a potential interaction between GLP-1 RAs and SGLT2 inhibitors for renal benefits, and will there be future studies on that?
So absolutely, I think for many years we had no drugs, and now all of a sudden we're inundated with drugs. So it'd be very exciting moving forward to see the additive effect of GLP-1 agonists on top of SGLT2 inhibitors. And I think we look forward to the trials that are upcoming, looking at these combination drugs. I think it would be interesting to look at them in the context of non-diabetics, but also lower GFRs, going down to GFR 20, and also in people who are maybe not completely obese as well. So I think there are many trials, I think, on the horizon coming, and we look forward to seeing their results.
Absolutely. But on that note of the eGFR 20, currently, if I have a diabetic individual, where I know in Scotland we can still prescribe GLP-1 RAs, is there a cutoff for eGFR I should be concerned about?
No, I personally don't think there's an EGFR cutoff. I think if a person is on dialysis, then there is a lack of evidence for continuing them on in that situation. But I would probably continue them on at lower GFRs.
Well, great. Coming from you, that's real reassurance. But again, you've covered a lot of this in your contribution to this special focus issue. So once again, I'm hearing it loud and clear from Samira and from Bianca. Do look out for the articles in this special focus. Today's roundtable discussion has just given us a really small insight. I think, may I encourage all the listeners to look out for this special focus coming out in the European Cardiology reviews. So on that note, I'd like to thank both Professor Bianca Rocca and Dr. Samira Bell for joining me today in today's roundtable discussion. Thank you.
Thank you very much.
Thank you.